Let's talk about understanding women with HIV who are lost to follow-up. The status of retention and care for women with HIV is a critical piece of the HIV epidemic. 23% of women have missed one or more medical appointments in the last 12 months versus just 20% of all people living with HIV. And among pregnant individuals, those who are younger, newly diagnosed, or in a serodiscordant relationship were more likely to become lost to follow-up. And many women fall out of care in that postpartum period. So studies have shown that the incidence of becoming lost to follow-up was about 21% by 12 months and 40% by 5 years postpartum. And this is always compounded by postpartum depression and the fact that many parents will individualize, or many individuals will prioritize the infant care over their own care. The effect of interpersonal violence on engagement in HIV care is a critical issue. If you take a look at this data, women who have experienced interpersonal violence in the last 12 months have worse HIV outcomes. They have more unmet ancillary needs, greater rates of depression. They're less likely to be retained in care and less likely to be on antiretroviral therapy, as well as have a sustained virologic suppression, and more likely to miss HIV-related appointments. Collaboration between HIV clinics and interpersonal violence shelters or organizations that serve individuals experiencing interpersonal violence can really help to improve re-engagement in HIV care. Black women make up 54% of new HIV diagnoses for women in 2019, despite being 13% of the population of women. And this has been identified as a priority population in the National HIV/AIDS strategy. Lower retention rates among Black or African American women have been demonstrated compared to white women, and there's often a failure to recognize the intersectionality of race, gender, and social determinants of health. And this intersectionality places people at a disadvantage and a higher HIV risk in general. And the strong Black woman stereotype can often be detrimental to mental health, studies have shown. There are barriers to and facilitators of retention and care for pregnant and postpartum women with HIV. And some of the barriers include stigma and fear of disclosure, inadequate social support, low health literacy, pregnancy-related symptoms, poor mental health, again, interpersonal violence. Sometimes distance from clinic can be a huge barrier, and negative provider attitudes as well as family responsibilities. Facilitators are belief about the importance of care for themselves and their child, support from partner and family, integrated HIV and maternal child health care. So again, co-location of services can be really critical. We've already established that oftentimes new parents will put their child's health, that infant's health, above their own. So if you're going in to take care of the child, it would be amazing to be able to get a medical visit for the parent as well. Services addressing mental health and interpersonal violence also to be available on the same site is very useful. And then expedited care as well to get individuals virologically suppressed is critical. The social ecological model of retention and care for pregnant people and postpartum individuals is really, really important. And it's complicated. You can see that there's individual components, community and society components, peer and family, as well as environment as well. And at the center of this is really making sure that there's a proper transition from interpartum care to antenatal care to postpartum care. We really want to make sure that that individual is being supported through that process. And retention and care will optimally involve individual, peer, community, and environmental collaboration, in addition to being linked to OBGYN and HIV care services. Strategies to re-engage individuals with HIV, the use of peer navigators or counselors is really important here. And it resulted in a 10% increase in retention and care and viral suppression among women of color. Peer navigators have been helpful for pregnant or postpartum people as well. Co-located care, including with OBGYN services, is really, really helpful. So making sure, again, that individuals can access more than one service at a location can really increase the likelihood of engagement in care, both OBGYN care as well as HIV care. Providing childcare during the appointment is very helpful in the postpartum period. You may want the individual to have some time to talk to their provider without interruption, and making sure that they're tending to their own needs is important. So there have been multiple strategies that have been most effective in re-engaging women in HIV care in the clinics that I've worked in. So making sure that we have a multidisciplinary team to support women in particular, whether these are trans-identifying women or individuals who are assigned female at birth. There are intrinsic needs, whether it's related to interpersonal violence or child care, that the health center can provide. And so we've had peer navigators have been very helpful. Having a specialized women's team has been very useful as well. A support group that is especially a safe place for women to come is very helpful too. So I think creating an environment where women feel held and supported and seen is very useful and can be incorporated actually with very little additional resources.